Diabetic Knowledge Academy. To see 36 people joining this afternoon is amazing. Like I thought when the meeting started, there would be only one or two people apart from the organizers and the speakers. As usual, it happens in the afternoon meetings. But it is amazing to see some 36 people who have joined in this meet. And I would also like to thank Dr. Bhavadani Madam, and I'm a great admirer of her because she shows so much of enthusiasm in participating in our meetings, no matter who conducts the meeting, and keeps us encouraging. So
Thank you, Doctor.
Madam, thank you, madam. Really admire you, madam. Wherever you are, there is like some vibe, positive vibe there.
Thank you.
So, like both, as we all know, that diabetes has been a silent killer or a silent disease, but diabetes manifests only through the stomach and the mouth. For most of the patients, patient is not going to suffer kidney disease unless he is in the end-stage kidney disease or in renal replacement heart. He is not going to suffer the heart attack unless he is taken to the hospital and given the bill. But as far as this enteropathy is concerned, this is the major complaint of any patient in any OP setup, we all know. So, the diabetic heart part, if the patient comes, he goes to the cardiologist. And once the patient is diagnosed with kidney disease, the nephrologist takes over. And luckily for us, only GA complaints we are still managing, not much into the territory of the gastroenterologist. So it is better we keep this among within ourselves and know a little of this GA problems in diabetes mellitus. Because as per the slide, it shows that nearly 75% of the patients with diabetes mellitus have some or other GA problems, which also we see in our clinical setup. And most of this can be treated by us. So it is very important we know about this. So there is a factor that affects the GA involvement is just diabetes and poor glycemic control. The presence of diabetes, the treatment of diabetes, and the complications of diabetes all will somehow manifest with GA symptoms. Next slide. So there are so many mechanisms by which the GA complications can happen. It can be because of the neurological problem, or it can be because of the vascular problem, or it could be just because of the drugs that we give. Next slide. But most of the time, the proper diabetic enteropathy is meant to be the autonomic or involuntary neuropathy that will lead to abnormalities like the intestinal motility, sensation, secretion, and absorption. So all the parts or the parameters of the GA is affected. So the different nerve fibers that affects the GA, if it is affected, it manifests differently. So coming to the parts it affects, as I told you earlier, it could affect starting from esophagus to the large intestine to the other appendages like gallbladder. And of course, the major problem is now the fatty liver disease that is associated with diabetes, and that is taking the world by storm because of the pharmacological advances. Now, coming to the esophagus, diabetic gastroesophageal reflux disorder, we know that that is one of the most important drugs. Next slide. Manifestations that the patient comes to us. Next slide. This slide shows the picture of a esophagitis, and most importantly, the third one, the esophageal candidiasis. Next slide. Yes. So any patient who comes to us with any GA symptoms, that is the upper GA symptoms, let us not stop short with treating the GERD or a proton pump inhibitor. In all cases, we must always suspect esophageal candidiasis, especially if the patient has some loss of appetite and also loss of weight. In all those cases, definitely submit the patient for an EUGSOP. Then we do a esophageal motility study. Next slide, please. So how do we do an esophageal motility study? We do it very simply by the radionucleotide studies that are now available in most of the corporate hospitals. Coming to the stomach, diabetics can either cause gastroparesis or sometimes because of the drugs that are involved, it can cause hypermotility disorders. Next slide shows the picture of the food debris that remains in the GA or the stomach after say around 3 hours, but by the time it should have been emptied. So it can be one of the definitive diagnosis of GA, gastroparesis. So how do we diagnose it? Next slide. We diagnose it basically by upper GA endoscopy. We do GA barium studies. And then now the most definitive study is the nuclear medicine gastric emptying study. Just costs somewhere around 2,000 rupees in our part in Coimbatore. And more or less the patient takes it easily unless otherwise contraindicated. The patient generally doesn't want to put a scope inside his stomach. So upper GA endoscopy is better avoided. And also the patient needs a gastroenterologist for this. And as far as I know, the nuclear medicine consultants don't treat diabetes until today. So we better refer them for nuclear medicine gastric emptying test to get back the patient. If we send the patient to a gastroenterologist, he will definitely take over your patient. How do we manage it? Diabetic gastroparesis, like we all know, it is to be done with small frequent meals, avoidance of high fat, high fiber foods, smoking cessation if it is there, and limitation of the alcohol intake, and mild postprandial exercise, just something like walking. What are the drugs we use for gastroparesis? We can use the prokinetics like metoclopramide, most underused, but this is most effective drug I have seen. Domperidone, newer drugs like etopride, levosulfuride, syntapride, and prochlorpride, and now we have the acosciamide, and of course the ever-present erythromycin, but there is a chance of the patient developing tachyphylaxis, and over a period of time it may not work. So what are the novel therapy that the gastroparesis can have? It is the implantable gastric pacemaker when the nerves are totally off and prokinetic agents cannot work. So next comes the small intestine in diabetes mellitus. The small intestine, again, as we all know, is the place where the entire absorption takes place. But in diabetes, because of the delay, the stagnation of fluids can cause the bacterial overgrowth syndrome. That is the small intestine bacterial overgrowth syndrome. So this is one of the major complaints that patients will come to us. Central abdominal pain, bloating, diarrhea. We may attribute it to both the the regions like stomach or colon, but we generally avoid the small intestine in diabetes mellitus. So how do we diagnose it? We do a small bowel intubation for quantitative small bowel bacterial growth cultures, but this is generally an interventional procedure. Instead, lot of labs now offer breath hydrogen testing for bacterial overgrowth. This is very simple and it is done at a cost of around 600 rupees. So numerous antibiotic regimens have been shown to be effective if the breath hydrogen testing is positive in a patient who has bloating and abdominal pain. Generally, it is better to start an antibiotic for a short duration, say around 2 weeks, like a very broad spectrum tetracycline. And if the patients are intolerant to tetracycline, gastric friendly antibiotic like ciprofloxacin or amoxicillin can be used. And ciprofloxacin, when used, we must be cautious about using the sulfonylureas and other hypoglycemia induced. Enteric neuropathy, again, is a small bowel issue which can cause chronic abdominal pain syndrome. Only treatment for it is proper pain relief. Tricyclic anti-medications, antidepressants can be used, but amitriptyline, but this can again cause constipation and follow on. So it has to be very carefully administered in the select few patients. And of course, there is an association of celiac through with diabetes mellitus. And then comes the colon in diabetes mellitus. Now, this is the most important part where we'll have to be very careful and we should not attribute it to the diabetes alone. The diabetic diarrhea and constipation, especially in the elderly, typically mimics the CA colon. So Even if the patient very clearly, if we know that the patient still has diabetic diarrhea and constipation, it is always better to subject the patient for a colonoscopy before we give a definite diagnosis of diabetic diarrhea and constipation. We all know that in colon there will be an alternating diarrhea constipation or constipation alone or diarrhea alone, very refractive to treatment, and this is the most difficult part of the diabetic management. Anything and everything, generally our patient will have complaints pertaining to stomach. Like either gas only they will tell. Whatever it is, it will be gas. I have even seen patients complaining to me of gas after taking pan, and they tell it is because of the pan. So we will have to be like this sort of cases. We will have to refer to the gastroenterologist and save our times. So now, next slide, we can see here the workup basically is, sorry, the colon in diabetes, as you told. Next slide, please. Yes, this is how the colon looks. The mucosal mucosa is totally flat and sometimes inflamed because of the stagnation of the bacteria. And next comes the workup. How do we work up a diarrhea and constipation? So, like it is the same as in any other patient. Most important thing to be ruled out is a CA. So we'll have to do all the investigations to rule out the CA, and if it is a straightforward case of diabetic diarrhea, we can give either diphenoxylate or loperamide, and then if it is a constipation, we give laxative. And the patient will definitely not take laxative for like long term because of so many like opinions that they have, and naturally they will go to some avarambu pudi or the pet safa kind of thing. So then comes the next line of treatment, like we can have the empiric trial of antibiotics or pancreatic enzymes. We can give pancreatic enzymes a trial like the lupase or pancreatin. We can try to for a short while and then we'll find out. And then comes the newer 5-HT receptor antagonist, allocetrone, and this could be helpful in the irritable bowel syndrome. In severe cases, we could even try octreotide injections, but not all the patients will benefit because of octreotide diarrhea. The last part of my talk would be the gallstones. Diabetic patients will have increased incidence of gallstones and gallbladder problem. They have to be treated. They have to be treated only if the gallstones are symptomatic. Unless otherwise the patients have symptomatic gallstones, it is better not to treat it. Now coming to my final slide, the take-home message. Enteropathy in diabetes is very common, and this is one of the most common complaints that we get in day-to-day practice, and it has to be thoroughly assessed to the cause because most of the cause is treatment. Most of the cause is treatable, and also the patients are very satisfied if you are going to give them a good relief. And there is a direct relationship between the duration of diabetes and the degree of glycemic control to the severity of the GI problems. And then when the patient always tries to blame us with the statement that our tablets has caused his disease, we can always blame him back that it is that he has not taken our GI tract can be affected, starting from the mouth to the aboral end. The workup has to be very thorough because it overlaps with many other serious conditions like inflammatory bowel disease and carcinoma. So we will have to take meticulous pains, explain to the patient why we are working up, and finally come to the diagnosis of diabetic gastropathy or diabetic enteropathy. So in addition to the pharmacological therapy, it is very important that the diabetic management is also very important. And most importantly, the psychological counseling to the patient is very helpful in the the enteropathy. Thank you so much for your patient listening. Thank you so much, sir, for giving me this opportunity.
Thank you, Vengo. You have nicely highlighted from mouth to anus.